I hope you guys are all doing well today. Good afternoon. My name is Renee Calkins. I'm the Education Manager here at the Michigan Center for Rural Health. And for those of you who are unaware, the Michigan Center for Rural Health is a nonprofit state office of rural health. And a cornerstone of our office is to provide free education to rural healthcare providers. I will be the facilitator of this program, and today I would like to welcome everyone to today's Social Work Behavioral Health Grand Rounds. This program is jointly provided by the Michigan Center for Rural Health and the Michigan Social Work Collaborative and the Michigan Certification Board for Addiction Professionals for continuing education. One contact hour for social work and MCBAP. And this 1 hour for MCBAP is specific. Criteria for successful completion is please participate in the learning activity. Your attendance is being recorded via Zoom, so I can pull that up. And you have to complete the post-session evaluation at the end of the session. There is no commercial or financial disclosures to disclose. There's no commercial support, and no one has any relevant financial contributions to disclose. And then today, your learning outcome is to have reported increased knowledge of writing an individualized evidence-based treatment plan that guides the client's treatment using assessment and the creation of treatment plan, monitoring progress throughout treatment, and how the treatment plan relates to discharge planning process. And with that, I would like to welcome and introduce our presenter today, Jenny Gruber. Jenny has been a project associate with the Northern Michigan Opioid Response Consortium for the past year and a half. She graduated with a master's in social work from Spring Arbor University and has over 6 years experience as a clinician and program administrator. I can't talk today, excuse me, administrator for the healthcare setting. And I will go ahead and stop sharing my screen so Jenny can share hers. Thank you all for being here, and thank you, Jenny, for presenting today.
Is that showing up okay?
Looks great.
Great. Hi, everyone, and welcome. Thank you for taking your time out of your day to join us. So this is our second webinar in this series. So back in January, we discussed clinical assessments, and we received a lot of good feedback from that on things to include going forward. So we are taking that feedback and including that today. One example is we got a request for specific case examples. So we're going to introduce that today and moving forward as well. And if you did miss the first webinar, no worries. We will recap anything that is applicable to today's topic. This is a series, but if you have to miss one, they do stand on their own as well. And then before we jump in, just a reminder that Renee will be sending out a copy of this PowerPoint and the video from today. And if you have any questions, we'll make time for Q&A at the end. So this webinar is going to be discussing medical necessity criteria in addiction treatment. And primarily, we're talking about the ASAM criteria. So the ASAM criteria is a set of criteria that is put forward from the American Society of Addiction Medicine. They use a multidimensional approach to assess a person's strengths, resources, social support, and their assets. And multidimensional means that we're looking at more than just their addiction. We're looking at the person as a whole. And you'll see when we go through the criteria, there's 6 different dimensions that we're going to be looking at today. So the ASAM criteria helps us to determine the best level of care for the person's substance use disorder at the time of assessment, accounting for their need for medical oversight and safety. So there is different criteria, both medically managed and not medically managed, that we'll talk about. And the ACM criteria can be used at entry into treatment. So that'll be the initial authorization to care, and also at different levels of care on the continuum. So why do you need to know the ACM criteria? First is client advocacy. So in substance use treatment, in order for a client to receive services, they must first be approved by the entity that is funding that treatment. All services must be medically necessary, and someone is responsible for proving that those services are medically necessary. So if we don't know what qualifies somebody to receive services, then we're not able to effectively advocate for them. Mental health parity laws will cover more in depth later on, but in a nutshell, it requires insurance coverage for mental health conditions, including substance use disorders, to be no more restrictive than insurance coverage for other medical conditions. So we should expect that they get adequate amount of time and the appropriate level of services to meet their needs. We also want to know how to appeal a denial of services. So if the request for services is denied, your client has the right to appeal, and this can be a daunting process for the client. And by knowing what those processes are, we can help guide them through this process. Michigan does require the use of the ACAM criteria for all Medicaid clients. So if you're working with the Medicaid population, then this is the one that you will use, and we'll talk more about commercial insurance clients and those requirements towards the end. The ACAM criteria is one of the most evidence-based and widely used criteria. So again, we're looking at the individual as a whole, and it informs our treatment planning. So the first instance when we are talking with the client and getting approval for services, that is referred to as the initial authorization for services. And this is when a client enters into treatment. We discussed a lot at our last webinar, all of the different factors that goes into what determines a client's level of care. So there might be initial screens that are completed by the insurance company, or if they have Medicaid, by the PIHP. There's also intake information that's collected by the agency or potentially another agency that completes our referrals. And finally, there's the assessment that's completed by us as the clinicians. And so if you do your own assessment, we want to be asking all of the questions that are going to give us the data that is needed to prove medical necessity and determine the level of care. And at the end of the assessment process, we should have enough information to complete the ASAM report. And we're going to talk about what each of the dimensions are shortly. But first, the information that we provide in each dimension should be pertinent and individualized to the client and their current risk, including historical and current information. So one example of where historical information is just as important, if you think of a client that is coming into treatment potentially for detox services, we want to ask if they have a history when they're withdrawing of seizures or DTs, because that, even if they're not experiencing that currently, it is going to impact what level of care that we put them in. And information should support why the treatment is needed at the requested level of care and what the client is working on in order to move them towards a lower level of care in a reasonable amount of time. So we're going to start first with dimension 1. And again, after each one of these slides, we're going to have a case example that we're going to go through. And instead of asking you to guess which level of care the client is in, what we want to put him in, I'm just going to tell you, because I think it's more important, since we have such limited time, for you to kind of note the clues that you're seeing, why the client would need those services. So our case example, we'll call him Frank, and we want to put him at least in a 3.7 medically managed withdrawal level of care, but possibly he might also need to be under level 4, which is hospitalization. So before we start that case example, some of the items that you want to consider in Dimension 1, what substances are they using? And we want to include the frequency, the duration, the amounts of each substance, and their date of last use. We want to note if they have any risks for withdrawal. If we have access to SIWA or COW scores, for example, we want to include those. And if there are any current signs of withdrawals, we want to list the symptoms. And we want to know any history of withdrawal complications such as DTs or seizures. All right, so we'll start with Dimension 1 with Frank. Look for the clues that he should at least be in a medically managed, so not a clinically managed level of detox, but medically managed with medications and possibly maybe even hospitalization. That's going to depend a lot on what your agency offers. So some places don't have 3.7 withdrawal management services, and they do need to send the client right to the hospital. But some places do offer 3.7 medically managed, and the medical provider might be comfortable keeping an eye on them. So client reports he drinks on average 2/5 of vodka per day, starting when he wakes up in the morning until he passes out. Client reports he has been drinking this amount for at least the past year. He drank until the time of his admission 6 hours ago. Client's current withdrawal symptoms include anxiety, shaky hands, headache, nausea, vomiting, insomnia, and sweating. He reports a history of seizures, hallucinations, and DTs when he attempts to quit drinking on his own. And his current SIWA score is 20. So this is just an example of how Dimension 1 on an ASAM report could be laid out. And we see the clues here. He's drinking quite a lot per day, all day, for quite some time now. And up until he admitted, so it's been 6 hours, so he might have some withdrawal symptoms, which he does. But also very importantly, he has a history of seizures, hallucinations, and DTs when he's withdrawing. And that is something that we need to have medical monitoring oversight for. And I just included at the bottom, if you do a SIWA score, it tells you at the bottom of the assessments kind of what level of care might be appropriate. And it does say that clients with a score of at least 20 or greater, they do frequently require medication for withdrawal. And they might also require admission to the ICU for observations for seizures or development of delirium tremens and more frequent medication dosing. So again, when we go into the second dimension, we're going to be looking for clues that medically managed withdrawal services are appropriate. And some of the items that you want to consider is, does the client have any physical illnesses other than withdrawal that need to be addressed or that might complicate treatment? Are they taking any medications, any chronic conditions that would affect their treatment, and any history of hospitalization? And this might also give you some insight too, because we know that once they're safely detoxed from substances, that we're going to be also looking at what comes next. And so we want to look at how complex their case is. And this client is probably going to go into at least a 3.5 high intensity residential level of care. There's a lot of other factors, but just based on this report alone, that's what we would be kind of looking at. So we'll go back to Frank. So client reports he has chronic back pain for the last 2 years resulting from a motorcycle accident. He reports that the alcohol helps with his back pain and becomes distressing if he goes more than a few hours without drinking. He reports he barely eats as he has no appetite. He's not taking any medications. However, he is prescribed Zoloft, 50 milligrams 2 times daily. He's not taking his medications in over 6 months after losing his Medicaid, after not following through on the requirements needed to maintain coverage. He reports 2 hospitalizations in the past 2 years. So he was hospitalized following his accident 2 years ago. And most recently was 1 year ago after attempting to detox on his own. So we do see a lot of clues here that this is a complex case, and he's got a lot of things that at the clinical level, we aren't going to be able to really address with him without that medical piece to this. So we do want a medical provider involved here because he has got the issue of chronic back pain, and that pain is going to return. And so we have to figure out getting him working with somebody in the medical field that can help him kind of manage that. We also note that he has poor nutrition. He might be arriving dehydrated. Then we have this whole medication issue to figure out that he'll probably need to go back on some kind of medication. And these are all things, of course, that we wouldn't be able to help him with on our own without that medical high level of care. And also, if we note, he did have a hospitalization, so he tried to detox on his own and he had to go to the hospital, and that's likely because of the things that we saw in Dimension 1. And so moving forward, when we go through the other dimensions, these are all still applicable in detox, but when we go through dimensions 3 through 6, we're kind of also looking at the level of residential or outpatient level of care that this client is going to need after detox. And so moving to dimension 3, let's see. So we want to ask, have you ever been diagnosed with a mental health disorder? So if so, what? Instead of saying, do you have any mental health disorders? Because some clients might self-diagnose, and it's all right if we want to put in our report that the client feels that they might have some PTSD, but they've never been diagnosed. But we do want to make that distinction because it's important for the medical provider to know, and anybody else that's working with them, and also what their treatment plan is going to look like. So if they haven't been diagnosed, but they feel like they might need it, then that might indicate that there needs to be some testing or outside referrals. But if they have been diagnosed, that could indicate something else. So we also want to look at, do any emotional, behavioral, or cognitive problems appear to be an expected part of the addictive disorder, or do they appear to be autonomous? Are they able to cope with any emotional, behavioral, or cognitive problems? Are there any history of mental health medications, any psychiatric hospitalizations, any history of therapy, and any current suicidal or homicidal ideations or a history of those? So back to our case example, look at the clues that the client might need to have a more complex level of residential services versus outpatient or even a very low intensity residential level of care where they might only get 5 hours of programming a week. Okay, so the client reports they have a diagnosis of major depressive disorder 3 years ago. He reports his mother suddenly passed away 5 years ago. He had a close relationship to his mother. He reports no history of suicidal or homicidal ideation, no history of self-harm. There's no history of psychiatric hospitalization. He briefly tried outpatient therapy after being recommended by his PCP, but he quit after 2 sessions because he didn't feel ready to talk about his mother. He was prescribed Zoloft, but he's not taken his medication for 6 months due to losing his Medicaid coverage. And prior to that, he did not regularly take his medications due to the drinking and forgetting, or he did not like how his medication made him feel when he was drinking. He reports he self-medicates with alcohol and feels hopeless and depressed when he is not drinking. So some of the clues here that they might require a high level of residential care. So we have this issue that he has where he's lost his mom and he hasn't been able to talk about it. So that's something that's going to go on his treatment plan and hopefully be addressed. And he doesn't really have much of a history of treatment to address these issues. Again, we have the medication issue where he was drinking while on medications, forgetting, and then he lost his Medicaid, and now he just doesn't take them. And so we have these factors that are going to return since he's self-medicating with the alcohol. So these factors will return, and we'll need to help him address these things as well. Dimension 4 is about readiness to change. So some of the items that we want to consider in Dimension 4 is, what is their level of emotional or cognitive awareness of their need to change? So what stage of change are they in? What is their level of commitment to and readiness for change? What has been their cooperation with treatment? And do they have any awareness of the relationship of alcohol or other drug use to any negative consequences? So back to Frank. The client appears to be in the preparation stage of change. He states he's tried cutting back or quitting drinking on his own, and he's not been successful. The client states, "I am sick of living my life like this, and I need help." Client has no history of SUD treatment. He appears to understand the negative consequences of his life are the result of his alcohol use, and he states, "If I don't do something different, I will end up in jail or dead." And I wanted to kind of structure this ASAM dimension in a way to kind of show a point that this dimension on its own, this could actually be for somebody that is in an outpatient program or even IOP. So this one dimension on its own doesn't tell you the totality of the person. It doesn't give you insight fully into what level of care we should put them in. So it's great that he's prepared and ready for change. That's really going to help him in his treatment. But this could be a dimension that fits into another level of care if we didn't have all the other factors. So dimension 5, we're talking about relapse, continued use, or continued problem potential. So we want to look at if the client is in immediate danger of continued severe mental health distress and or drug or alcohol use. Do they have any recognition of, understanding, or skills in which to cope with their addiction or their mental health disorder in order to prevent a return to use? How severe are the problems and further distress that might continue to reappear if they are not successfully engaged in treatment at this time? So our report should kind of prove that if the client is not at this level of care, this is what could happen. Are they aware of their relapse triggers, ways to cope with their cravings, and skills to control impulses to use? And then also, do they have a previous history of treatment? And if yes, is there anything different this time? And so sometimes if a client has been to treatment multiple times, the funder will actually ask this question before authorizing services. They might say, okay, well, he's been here 6 times before. What's different this time? And so we want to make sure that if that's the case, we include that piece. It's a good thing to ask the client and see what their feedback is, and maybe take some of the things that they say and carry that over into their treatment plan. So back to Frank. The client reports his only period of sobriety in the past 2 years lasted 24 hours after attempting to stop drinking on his own and ending up in the hospital. The client left the hospital AMA to drink. He reports his current cravings are 10 out of 10. He has no coping skills and no history of SUD treatment. While he expresses a willingness and a readiness to change, he reports fear of his back pain and depressive feelings returning. Client admits to driving several times under the influence, but he has never been caught. The client reports he isn't sure what his triggers are, and he doesn't know how to handle his cravings and impulses to drink other than to continue drinking so they go away. So again, we're seeing a lot of clues in this dimension that he does need a higher level of services, whether that be 3.7 residential or 3.5 residential is a lot more commonly available. So he's most likely going to need that unless your facility does offer that. I'm not aware of too many in Michigan. But we see that he's not able to abstain from drinking on his own at all. The 24 hours was only because of his hospitalization. He has no history of SUD treatment, so he hasn't had a chance to learn coping skills, learn how to manage his cravings, which are high, his triggers, which he doesn't know what they are. So this is all telling us he needs a highly structured residential setting because he needs a lot of that programming and individualized therapy to get these skills developed. Our last dimension on the ASAM criteria is we are looking at their recovery and their living environment. So do any of the family members, significant others, living situations, school or work situations pose a threat to their safety or their engagement in treatment? Do they have any supportive friendships, financial resources, or educational or vocational resources that could increase the likelihood of their successful treatment? Are there any legal, vocational, social service agency or criminal justice mandates that might enhance their motivation for engagement in treatment? And finally, we do want to look at any transportation, childcare, housing, and employment issues that need to be clarified and addressed. So the last dimension, back to Frank. So we see the client is currently homeless and he's unemployed. He's never been married and he has no children. He's been couch surfing with a few friends, but he states at this point, they have all told him he is not welcome to return. He is unsure where he will go after treatment. He reports he has no supportive family and his only support was his mother who passed away. He had a few supportive friends, but they no longer want to be around him due to his drinking. He reports no current or previous legal involvement. Client has a car but does not have insurance and reports it breaks down all the time. Client expressed an interest in connecting with the recovery coach while in treatment. And so we're going to kind of talk about like the different levels of care. But really quickly, I noted at the beginning that we're going to be using these case examples in the future webinars. And so we're going to take this case example that we had of Frank, and we are going to kind of carry him over into the treatment planning that we're doing in June. So we're going to create a treatment plan for Frank. And so I did want to note that he was a pretty complex case, and intentionally because I wanted every dimension to have some kind of an example. However, you're going to be working with a lot of clients where every single ASAM dimension does not have to be full of things. So if you're working with somebody in the outpatient level of care, for example, chances are likely that you might have a dimension 2 where it's simply client has no biomedical conditions, and it's very like there's nothing in here, we don't need to address anything on the treatment plan, so we don't have to carry everything over. We're just doing it for purposes of having examples for this and the future webinars. So if you see at the bottom, withdrawal management level of care, because we don't have any time like to really dive into all of the levels of care and what they include, I included a link. And so when Renee sends you this PowerPoint, you'll be able to like click in there on it. It's called Treatment Policy 13. And this goes really deep into all of the withdrawal management levels of care. It's a document from the state of Michigan. And it'll tell you what the criteria are for clients that need to go into these levels of care and what level of services that they should receive. So if we go through the withdrawal management levels of care, we see we have level 4, which is hospitalization, 3.7, which is medically monitored withdrawal services. And then there's also lower levels of care. So some clients might have a lot lower risk factors, and they would be fine to go into a clinically managed residential withdrawal management. There's also level 2, which is ambulatory withdrawal management with extended on-site monitoring, and level 1 is the lowest level of withdrawal management, and that is without extended on-site monitoring. And so again, this policy, treatment policy 13, will tell you what all of the different levels of care include as services and kind of some of the criteria involved in placing people. We also have our other levels of care in addiction treatment. So we're looking at like outpatient and residential type levels of care and not withdrawal management. And so early intervention is the lowest. This would be somebody that doesn't have a substance use disorder. Maybe they got caught drinking and driving, and they need to attend a class. So it could just be an assessment or some classes. Level 1, that's outpatient, up to 9 hours per week. 2.1 is what we call outpatient or intensive outpatient. And really what kind of determines what level of outpatient services a client is in is the amount of hours that they're attending. And so 9 hours, but no more than 20 would be intensive outpatient. 2.5 is partial hospitalization. That's also called PHP or day programs, and they need to be attending at least 20 hours a week, but less than 24-hour care. So they're not living at the facility. They're going home at the end of the day, but they're going to a lot more classes, and there's more individual therapy involved as well. So then we get to the residential levels of care. 3.1 is low intensity residential, so they'll have housing. However, they're only going to be required to attend programming 5 hours a week. And they're going to be looking at things, specific topics such as relapse management. 3.3 is population specific, high intensity residential. I am not aware of any in at least Northern Michigan. I don't know if there's any like in Southern Michigan. This is a very rare level of care that is offered. It is something that's in the ACAM criteria, but chances are most likely if you do get a client that needs this level of care, you're going to be placing them like in another level of care, such as a 3.5, and just making those modifications. And this is for individuals who need a slower pace. So people with traumatic brain injuries or developmental disabilities. And then we go up in intensity in residential. So 3.5, these are designed for people with serious psychological or social issues who need 24-hour oversight and are at risk of imminent harm. And so this would be more appropriate for our case example, because there's all of those complex issues. He couldn't possibly get all of those things addressed with only 5 hours a week. And 3.7 is high intensity residential. So there is a high intensity 3.7 residential, and there's also a 3.7 withdrawal management, but those are 2 different levels of care. And again, level 4 is hospitalization. And so they're not able to function in any other environment. And I want to make sure that we have enough time for Q&A, so I won't take too long on any one of these things, but I did want to touch briefly on kind of how the ASAM ties into some of the other aspects of an individual's level of care. So we covered assessments quite in depth back in January. And if you're working with a Medicaid client in Michigan, then you'll likely be familiar with ASAM Continuum for adult SUD services, unless you work with youth. But for adult services, there is ASAM criteria. It's a biopsychosocial assessment. It covers all of the 6 dimensions. And then it also includes other tools that we can use. And ultimately, it generates a report, which includes a recommended level of care determination. So during the assessment process, we're determining if a client is appropriate for services, aka medical necessity. We're determining what level of services they need, and also how long we think they might need. And we're also informing our treatment planning, and assessments should always be revisited throughout treatment. Things do change quite quickly for some people, and so we want to make sure that we are kind of upgrading their treatment plan when they're no longer benefiting, and looking at when it's time to step them down to the next level of care. Because with the ASAM criteria, they do want the client to be in the least restrictive level of care that they need. And we always want to be kind of looking at the next level in the continuum and how to get them there. So treatment plannings, we won't go into how to make a treatment plan until June. But the ASAM criteria guiding principles, again, uses that multidimensional treatment planning approach. So we're creating all of our goals based on what is in our ASAM report. And we're looking at the person as a whole. And there are 4 components of a treatment plan. So there is the problems, and those are the things that we're going to pull out of the assessment. There's the goals, what are they going to work on? And then we have the objectives and their interventions. And so we want to go through the ASAM dimensions from the assessment and look at what problems were identified, what dimensions include problems that need to be carried into the treatment plan. So again, if you're at a lower level of care, there may be some dimensions that you just don't need to address, and that's fine. We want to create goals, objectives, and interventions that address those issues identified in the ASAM. I mean, if you're not a clinician and you are a case manager, or if you're a recovery coach and you have access to their assessment, you might not be the one that is creating the treatment plan, but it's still beneficial to be familiar with their treatment plan and what kind of things that they're working on, because there's going to be a lot of those things like housing and employment, or if they're interested in connecting with a recovery coach that you can help them with. Progress notes refers to individual therapy notes and also group therapy notes. And one of the mistakes that I made like early on when I was a new clinician is not really understanding what an individual session is supposed to be about. So I came into it thinking, what do you want to talk about today? No real structure, just letting them talk, and maybe the conversation was beneficial. But then at the end of the session, well, what did you address from the treatment plan? Oh, well, I didn't. And so these are all things that when an auditor comes in and looks at your progress notes, that they're going to look to see if you include. So we want to note in individual therapy and in group therapy, what problem from their treatment plan was addressed in that session. It could be more than one. What interventions did we use during the session? What was their response to the interventions? Did they participate? Were they engaged? Maybe they appeared to be disinterested. We want to make sure that our interventions are tied to the assessment and the treatment plan. So everything is interrelated. Their assessment of how the client is progressing on their treatment plan. So examples when you could put as evidenced by, that's where you'll see that word used, that term used a lot. And then any therapeutic homework or other action steps that it says the counselor, but again, if you are not a counselor and you're like a case manager, still include what are you going to work on with them next. And it could be as simple, if it's a group note, the client will attend the next session. It doesn't have to be something complex. In an individual note, it's probably going to be a little bit more detailed. So really quick, the ethical considerations, I'll try to run through this more quickly just because I want to make sure we do have time for that Q&A. But if the level of care that the ASAM continuum recommends doesn't match the need that you come up with, that's normal, it's fine. If you agree with the ASAM continuum software due to clinical or resource reasons, you can and you should justify the discrepancy between the ASAM continuum recommendation and the actual placement. And so you want to select the option clinician degrees with the ASAM criteria recommendation. So the ASAM continuum uses an algorithm that helps to determine the level of care based on limited questions in the tool. So it might not be asking everything that needs to be asked that you can ask. And the cover page also makes these statements. It's not a replacement for your own clinical judgment. And use this instrument as one of many tools to determine the proper level of care. So the final recommendation of care is based on multiple factors. So we're looking at access screens conducted by the referral source. It could be a PAHP, it could be a commercial insurance care manager. We're looking at their general intake screens, any medical screens or clinical screens that were conducted immediately prior to or at their admission. Might be other assessment tools that might include the ASI, CEWA, COWS, all of those that your agency might utilize. It could be non-SUD assessment tools for their co-occurring conditions. And then also, this is very important, your clinical judgment based on an additional information that you have gathered from the client. So the ASAM continuum touches on many different areas, and you can use these responses to obtain that additional information that is not being captured. And again, assessors have the ability to use clinical judgment to override the ASAM continuum recommendations to best fit the level of care indicated by the combined factors above. Again, if we are doing that though, we just want to make sure that we put why. This is why this recommended level of care is not going to work for this client. Ignore the number 3 there. I forgot to delete that out. This is number 2. So what do you do if your request for authorization has been denied by the funder? So there's a few different things to consider here. First, was your request for services actually denied, or is the funder just seeking additional information that they need to make a determination? And so a lot of times, if maybe you didn't have all the information or you forgot to include something and they don't feel like they have enough information, they're not going to deny it, but they're going to say, hey, I need to know a little bit more about this before I can make that determination. Also, is there any more information that you could include or possibly obtain? So maybe you could talk, if you work in an agency with a medical provider, you could obtain information from them to help support the recommended level of care. And then finally, do you know how to request an appeal? So again, your client has a right to appeal if their care gets denied, but this is a daunting process for most people and something that they're likely going to need help with. We do want to involve them in the process. If you're working with a Medicaid client, then you'll be going through a PIHP, and right in their client handbooks is that kind of procedure on how to request an appeal. And you can also likely find it on their website. Commercial insurances, that is just going to vary, but it should be something, if you go to their website, that you can look up. And you'll likely need medical support, especially at the higher levels of care for those kind of appeals. So who is authorizing addiction treatment and looking at your ASAM report? So in Michigan, if the client has Medicaid, they're going through a PIHP, and depending on where they live in the state is what their PIHP is. So all 10 of them are listed here. However, I do want to note that because they are Medicaid entities, they're all using ASAM. So there's no differential as far as one's using this criteria. They're all using the ASAM criteria. They may have different processes on how much care that they're authorizing at once and little things like that. So you might have to do more frequent requests, but they are all using the ASAM criteria. Then we also have our commercial insurance And so this is its own kind of thing that I wanted to touch on today, because we talked about the ASAM criteria, and I'll dive a little bit more deeply into it in the next couple of slides. But here's some of the different commercial insurances that you might be working with, and they're all going to have their own processes. They're not going to be as smooth or as easy to deal with as PIHP. So the Mental Health Parity and Addiction Equity Act of 2008, this is something that you should be familiar with. I encourage everybody to just Google this and look at like all of the requirements that are in here, because this is something that if your client gets denied services for treatment, that you can kind of use in your appeal to advocate for their care. And this does require health plans to adopt and implement medical necessity criteria and SUD benefits that is comparable to the way the health plan adopts and implements medical necessity criteria for medical and surgical benefits. So we should expect that if they're coming in for a substance use disorder, that they're getting the adequate amount of treatment, because historically, care, and you might see this still, and this is why you want to be familiar with this act, but like restricting treatment and shortening the levels of care to unreasonably short periods of time. The health plans, so they do have discretion in selecting and applying their medical necessity criteria, which has allowed for tremendous variation in how the plans, so we're talking about insurance companies when we say plans, they make medical necessity determinations for SUD benefits. Some plans have also been kind of reluctant to disclose medical necessity criteria and their reasons for denial of services. And you have a right to this information because federal regulatory standards do establish disclosure requirements. So you should know what criteria that they need to meet to get services. But these practices can make it difficult for the providers to challenge denials and service authorizations or claims based on medical necessity. So the lack of the regulation and the flexibility that insurance companies have to develop their own criteria. So they may not be using the Medicaid, the ASAM criteria at all. We can see cases where a client has their care limited or denied their care to control costs. And so as a result of this, we know that addiction treatment is a matter of life or death for many. And so we just want to make sure that we have these tools and this knowledge of how to advocate for them. So you see here, 15 states require commercial insurance plans to use specific criteria or level of care. And each state has the ability to say, I want you to use the ASAM or this other criteria. I would say most probably choose the ASAM, but there are a couple of states that do not. But Michigan is not one that kind of holds our commercial insurance companies to that standard. And we also have, on the opposite side, 24 states require Medicaid plans to use specific medical necessity criteria. And Michigan is one of them. And so what does this mean? Really, when you have a client that has Medicaid, you're going to have an easier time getting them services than when you have a client who has a commercial insurance. So some of these other criterias that I would encourage you to Google and look up if you work with commercial insurance clients, be familiar with what criteria they are using. I know Priority Health, I believe, uses the interqual criteria. There's also the level of care for alcohol and drug treatment referral, the MCG behavioral health care guidelines, and some insurance companies might even use their own internal criteria. I'm not sure if they still do, but I know a few years back, United Healthcare was one that kind of was doing their own thing. But you do have a right to this information, and you have a right to know what criteria they are following. And knowing kind of those things will help you asking those questions. Finally, If you were at the previous webinar, you'll recognize this slide. I'll include them in all of them because this is kind of the common theme for all of this is a concept called the golden thread. And that just means that it's applied to the documentation in a client's episode of care. So the assessment, the treatment plan, the progress notes, even the interventions, the discharge plans, all of these are interrelated and kind of intertwined with each other. And it's not only something that is required for compliance, but it's also just important in delivering high quality care. So for example, when I had that session where I had no structure to my individual session, that was not providing the most important high quality of care. We should have been going through their treatment plan and really making the most of our time. And so we'll keep repeating this golden thread slide throughout. And then finally, before we open it up for questions, you'll see that Renee included this QR code to register for the June session. And we will be covering treatment plans in June. Then we're going to be talking about documentation, all documentation in August, crisis planning and intervention in October, and then finally wrapping it up with some discharge planning in December. If you have any more suggestions, they're very helpful when we're coming up with what to cover. Please complete the questionnaire that you're going to be sent. There will be a spot in there for you to do that. And if you think of something after that you didn't include in the questionnaire, please feel free to reach out and email me and let me know. And so with that, I will open it up to any questions.
Thank you, Jenny. We really appreciate your time here with us. Go ahead. If you have any questions, you can unmute yourself and just ask away, or you can type it in the chat as well.
I see. Oh, I have a direct message, but I think it's important. So I am curious as to how often the ASAM continuum is overridden by a clinician. I can only speak from my own experience where I was at. And I would say for me personally, and those that I worked with, quite frequently, I was working in a withdrawal management level of care and a 3.5 high intensity residential level of care. And so there were a lot of times where the issues that were asked didn't capture the full like risk that was there. And so maybe if somebody is working at a lower level of care, it might be more spot on or accurate, but that was my own personal experiences. I did have to override. We had clients that would get a recommended 3.3 level of care that had a traumatic brain injury, but we felt that we could still treat them. And because there was no other 3.3 facilities in the state that we could find, we just modified their treatment plan to include those supports that they would need. And the PIHP that we were working with was completely fine with that. But personally, I did have to override it quite a bit.
Thank you. Any other questions? Well, I just want to reiterate that we are very thankful to have you. And I'm going to share our post-session evaluation, and I'll also drop it in the chat here. If you can't use the QR code, excuse me. If you can, please, take it immediately. It will be open for a couple days if you have to hop on to another meeting, though. I will send a follow-up email with this link as well as the slides, and I will put this on YouTube so you guys can view it again. So thank you very much, and please feel free to stay if you do have any questions. And we look forward to seeing you not next month, in June.
Thank you. Bye-bye.
Bye, Liz.
Bye, Jenny.